A quick hello before we dive in. My name is Dr. Michael, a practicing GP here in Auckland. I help international medical graduates prepare for the NZREX clinical exam through focused OSCE tutorials. My sessions include small group practices and personalized one-on-one mock exams with detailed and practical feedback to help you build confidence in communication, clinical reasoning, cultural safety, and managing those time stations. If you're on the journey towards registration and practicing in New Zealand, you're in the right place. You can find more information about my courses and upcoming sessions on my website. Let's get started with today's topic. Alright, so today we're going to talk about some ear-related presentations. These are extremely common complaints in the general practice, urgent care, or emergency settings, and they also appear quite frequently in the NZREX. Patient may come in complaining of ear pain, hearing loss, dizziness, or ringing in the ears, or discharge from the ears, or problem with balance. Now, most ear conditions are benign. Things like wax impaction, otitis externa, or middle ear infections are very common and usually resolve with simple treatment. However, ear symptoms can sometimes represent something more serious involving the inner ear, cranial nerves, or even the brain. For example, sudden hearing loss, persistent vertigo, dizziness associated with neurological symptoms may indicate conditions such as vestibular neuritis, Meniere's disease, acoustic neuroma, or even a stroke. So when we approach an ear presentation, our goal is not simply to treat the ear symptoms, our goal is to determine where the problem originates. Whether it is outer ear, middle ear, inner ear, or is it a neurological cause. To do this safely, I rely on a structured history. I personally use several simple frameworks to make sure I don't miss anything important. Now let's go through this step by step. I always start with a simple introduction. Hello, I'm Dr. Michael, one of the doctor here today. Could I confirm your full name and age, please? Thank you. Well, nice to meet you. What has brought you here today? At this point, I allow the patient to explain the problem in their own words. Often the patient will provide useful clues immediately. For example, someone might say their ears suddenly went deaf this morning, or that the room spins whenever they lie down. Once the patient describes the problem, the next step is to clarify exactly what they mean. One important rule in ear presentation is never assume the patient's word match the medical definition. For example, many patients say they feel dizzy, but dizziness can actually describe several different sensations, so I'll always want to clarify what they mean by dizzy. So to the patient, when you say dizzy, do you mean the room feels like it's spinning around you? Or do you feel lightheaded, like you're wanting to faint? Or do you feel unsteady when you walk? This distinction is extremely important. If the patient describes the room spinning, that suggests a vertigo, which usually originates from the inner ear or vestibular system. Feeling faint may suggest a cardiovascular cause, while imbalance may suggest a neurological cause. If the patient reports hearing problem, I clarify that as well. Do you feel your ears are blocked? Or is the hearing reduced? Or is the hearing completely gone? Did the hearing change suddenly or is it gradually? Sudden hearing loss is particularly important because it may represent sudden sensory neural hearing loss, which require urgent treatment. If the main complaint is just ear pain, I explore it using the Socrates framework, like what we talked about before in the previous episodes. First, I ask about the site. Is the pain in one ear or both ears? Pain affecting only one ear usually suggests a local ear problem. Pain affecting both ears may suggest infection or systemic illnesses. Next, onset. When did the pain start? Did it start suddenly or did it start gradually? Sudden pain may occur with trauma or pressure changes during flying or diving, while gradual pain is more typical of an infection. Character. How would you describe the pain? For example, is it sharp, dull, throbbing, or pressure-like? Patient often struggles to describe pain, so giving examples helps them communicate their symptoms. Radiation. Does the pain spread anywhere else, such as the jaw or the neck? Ear pain sometimes comes from nearby structures such as the throat or temporomandibular joint. These areas share nerve supply. Associated symptoms. Have you noticed any fever, ear discharge, hearing changes, or balance problems? These associated symptoms help identify infections or inner ear involvement. Timing. Is the pain constant or does it come and go? Intermittent symptoms sometimes suggest pressure-related issues. Exacerbating factors. Does anything make the pain worse, such as touching the ear, cold weather, water exposure, or movement? Pain that worsens when touching the tragus or moving the pinna is typical of otitis externa. Finally, severity. On a scale of 0 to 10, how severe is the pain? That helps guide us about how urgent the problem is. If the complaint is not pain, if it's hearing loss, dizziness, then we use the previous mnemonic, the ODPERA, to explore the presenting complaint. Now, there is a special mnemonic that we have to remember, especially for ENT cases like this. It's called the DVTF. D stands for deafness, meaning hearing loss. Do you have any hearing loss? V stands for vertigo, any spinning sensation. T stands for tinnitus, any ringing or buzzing in the ears. F stands for fullness, meaning pressure in the ear, which may indicate Meniere's disease. Now, after exploring these symptoms, we have to check the red flags, which is very important. Most of your symptoms are harmless, but some can indicate serious infections, neurological disease, or stroke. So when I ask these questions, each one has a specific purpose. First, I would like to ask about fever or recent infection. Have you had fever recently or recent cold or flu? I ask this because many ear problems develop after upper respiratory tract infections. Viral infections can lead to otitis media or inner ear inflammation such as vestibular neuritis. Next, I ask about discharge. Have you noticed anything coming out of the ear such as fluids or discharge? If so, what color is it? Is it bloody, is it yellow, or is it clear? This is an important clue because yellow or pus-like discharge may suggest the infection, clear water discharge may suggest the trauma, bloody discharge may indicate eardrum perforation. I want to know about the trauma and pressure change. Have you had any injuries to the ears or recent air travel or swimming? Pressure changes during flying or driving can cause barotrauma or eardrum rupture. Swimming increases the risk of otitis media. Next, I ask about pain and swelling behind the ear. Have you noticed any swelling or pain behind the ears? The question screens for mastoiditis, which is a serious complication of middle ear infections. Then I ask about neurological symptoms. Have you noticed any facial weaknesses, facial drooping, or difficulty speaking? This is important because the facial nerve runs close to the ears. Infections or tumors in the surrounding area can affect the facial nerve. In addition, dizziness accompanied by neurological symptoms raises concern for a stroke or brainstem problem. Now, we also want to find out about vision changes or severe headaches. Have you experienced any vision changes or severe headache with these symptoms? Vertigo combined with neurological symptoms may indicate a central cause, such as a stroke or intracranial problems. I want to find out about previous episodes. Have you had similar problems before? This question helps identify recurrent conditions such as Meniere's disease or BPPV. Now, I want to explore the background history by using the PMAF-TOSA, the mnemonic that we talked about. Do you have any past medical conditions such as recurrent ear infections, eczema, diabetes, or immune problems? Are you taking any medication? Because some medications are ototoxic, meaning they can damage hearing. Do you have any allergies? Does anyone in the family have hearing problems? What type of work do you do to assess for risk? Certain occupations expose people to loud noises, which may lead to hearing loss. I may also ask about lifestyle factors such as smoking, alcohol, swimming habits, and frequent earphone use. Now, importantly, after this, we always want to check eyes, ideas, concerns, expectations. What do you think may be going on? Is there any specific thing you're worried about? What were you hoping I could help with today? Many patients worry about permanent hearing loss, so understanding the concern is very important. Now, after the history, I explained the examination. Thank you for answering my questions. I'd now like to examine your ears and assess your hearing to help identify the causes of your symptoms. I began with general observation, looking for fever, facial symmetry, or difficulty walking, then moving on to inspection of the ears for any redness, swelling, discharge, deformity, or skin changes. I want to check the back of the ears for any signs of erythema, which may suggest mastoiditis, and next I gently press on the tragus and move the pinna if the pain is present, which may indicate otitis externa. Then I perform the otoscopy to examine the ear canal and the tympanic membrane. If hearing loss is reported, I may perform tuning fork tests such as a Rene and a Weber's test to determine whether hearing loss is conductive or sensory neural. If vertigo is present, I might want to check the gait, balance, and the full cranial nerves. Now, the management depends on the underlying diagnosis. For example, Wax impaction may be treated with olive oil drops and ear suction. Otitis externa is usually treated with topical antibiotic eardrops and keeping the ear dry. Benign positional vertigo can often be treated with repositional maneuvers such as the Aplin maneuver. Meniere's disease may require specialist referral and lifestyle advice. If symptoms such as of neurological causes, such as stroke, then urgent hospital referral is definitely required. Before ending the consultation, I always provide a safety net advice. If you notice any worsening of your symptoms, any sudden hearing loss, severe dizziness, high fever, difficulty with balance or walking, please seek medical attention right away. Finally, I arrange a follow-up if necessary. I would like to see you in about 2 weeks' time to see how you're feeling. So that completes a structured approach to ear presentation. The key is not memorizing diagnosis, but using a clear framework that we talked about today. So I hope this helps, and I'll see you in the next episode.